Wonderful. So I'm so excited today to have the opportunity to talk to Dr. Chad Ruffin, and thank you so much for being here. How are you doing?
I'm doing well. Thank you for asking. Thanks for having me here. It's really nice to be able to chat and tell people more about hearing loss and cochlear implants. So thank you for having me.
Absolutely. So to kick us off, would you just share a little bit about your hearing loss history and how old you were or what your cochlear implant history is?
I was born with mostly severe to profound sensorineural neural hearing loss, and I was diagnosed at the age of 3 because I wasn't talking. I think I had some language, because my parents actually didn't suspect me of having hearing loss. I just wasn't talking. I understood commands and talking because I was lip reading. I was fitted with hearing aids, had a ton of speech therapy, and was mainstreamed in kindergarten. And I wore hearing aids all through elementary school, high school, and I pretty much stopped wearing them at the middle of college because they really weren't beneficial for me. And I wore an FM system to hear during academic stuff. So I was able to actually hear without lip reading with that, with an FM system. So I did really well with that, except I was just really super socially deprived. And I really didn't know what I was missing out on with my hearing loss. My parents took me to an ear specialist when I was in 8th grade, and they offered cochlear implants, and I said I wasn't interested because I was one of the first of the computer generation growing up, and I saw how rapidly computers evolved and became better. And I assumed that, you implant a computer inside your head, it was going to be the same thing. And what I didn't understand at the time, and I have a much deeper appreciation for now, is the degree that hearing loss plays on the impact that hearing loss has on global communication. Like, most people think that hearing is just being able to hear the words and sentences, and that's it, or kids get language. And people don't realize that hearing forms, or access to speech forms a basis of how we relate to one another. We use our hearing, and we combine our hearing with nonverbal cues. We think about previous conversations we have. We take in environmental cues in the moment, and we combine all of this information to create a mental representation of who someone is, what they want, where they want this conversation to go, what are their goals. And that is what is missed out by most people with hearing loss and most hearing healthcare providers. People don't understand that learning what to say, how to say, when to say it is, for normal hearing people, it's a visceral response. You kind of know what to say, when to say it, how to say it. We don't think about it like a super ton. And the kids with hearing loss, they don't get that visceral sense. These social neural circuits don't develop as robustly because they miss out on incidental learning. When you're focused solely on hearing the words within 5 feet of you, and you are not overhearing conversations at the next table, hearing how conversations are managed walking down the hall, your ability to really succeed at the highest levels, I think, becomes much more limited, because professional life is about how we communicate with each other at a very, very high level, and it's a constant. And I think that's one of the reasons why people with hearing loss, even if you give them access to speech, they continue to underperform in real life relative to normal hearing people, meaning they don't earn as much. They are not able to get the professional goals they want to. And this is, a lot of people think of, it's systemic ableism, and I don't think it can be called systemic ableism when the patients don't really understand how hearing loss is impacting them, and then our hearing healthcare system doesn't appreciate that aspect of it. And when I say appreciate, yes, we know in the research community, all of these things make a difference. But when it comes to treating patients, audiologists aren't reimbursed for auditory rehabilitation at the levels that I'm talking about, like how to teach people how to develop better soft skills, advocate for themselves with hearing loss. And I think that's really the next step and where hearing healthcare has to come.
Yeah, there's so much, so many important aspects that you just touched on. And oh, wow.
I'm sorry to fire
I
your
don't know where
brain.
to start unpacking that, but it's so true. It's so true. And also we're, on the flip side, dealing with the stigma of, just hearing loss in general, as people think it's a old person's, you know, thing to deal with. And the fact is, both you and I obviously are two products of hearing loss at a very young age that wasn't at birth. I think in the US they've done an incredible job, or much improved job, of doing the universal newborn hearing screening. But I've recently understood that not all schools or not all states require the hearing test at the start of the school year every year, which is how I got identified in first grade, even though in kindergarten the year before, nothing presented. So I think it's just so important that, we can sort of change that stigma and get the information out about, hearing loss is not only an old person's ailment. It can impact us, and especially at the younger ages, like you said. So to be able to hear with an FM system, or to be able to utilize hearing aids, and then go on to utilize a cochlear implant to be able to communicate and interact with our normal hearing society. So absolutely. What do you find? So now that you had, and sorry, so at what age did you say that you got your cochlear implants?
I was 21 when I got my first one, and I was 30 when I got my second one.
Okay. All right. Very cool. So what do you find even today is the most common misperception of a cochlear implant by people, whether it's patients or whether it's just by, colleagues or people that in general, that you would like people to understand more about?
I think two things. One is that there are very few medical conditions that actually rule out a cochlear implant. I mean, most people, if they need one, there's not going to be a medical reason that they can't get an implant. Like some people are on blood thinners, some people can't tolerate general anesthesia. Like there are ways around both of these. Like we do cochlear implants under local anesthesia now. That's number one. Number two is, I think that most people think that cochlear implants is this invasive procedure designed for stone deaf people. And reality is, the earlier you get your implant, the better you're going to do with it, because the neural circuits are there. The pathway from the inner ear to the brain and the hearing centers in the brain are intact. So most people, once they have problems hearing on the phone, I think that once they have problems hearing, these people who are implant candidates usually can hear on the phone fine, but they have to stream it to both of their hearing aids. And once they have problems hearing on the phone and they need both of those hearing aids, they're usually an implant candidate. But then again, that misses a subset of people who have very high residual hearing in the low frequency. So they can actually hear quite well in an exam room. You wouldn't even know that you may even be able to get away and not know they have a hearing problem. But in the instant that any amount of background noise is added in, they do very poorly. So you miss some of those out. So I think the biggest misperception to me is how invasive the surgery is. It's a safe surgery. There are infection risks associated with it. It's coming back up. Most of the risk of with an implant surgery is around the possibility of having some level of infection. And then the other risks with implant surgery are very, very low. It's a very safe procedure. And most of my patients, it's actually pretty rare for them to have pain the next day. I mean, I've had one patient go straight up to the Space Needle the next day. I mean, it's actually rare. I mean, if you take the initiative to control the pain around this time of surgery, it's not an issue. You know, I can say personally that when I've had my ear surgeries, I don't really have pain with them. You know, I can't sleep on that side, and that's the annoying thing. I get a little bit of insomnia and sleep deprivation for a month after surgery because I'm not comfortable sleeping on that side. So I think the complexity of CI surgery and the fact that you can actually get them much earlier and benefit from them sooner are the two most common misperceptions.
Okay, excellent. And it is such an important thing. And I know that, you know, all of us in the hearing health world and things are trying to get the information out about the link between untreated hearing loss and early onset dementia. Because I think, you know, people just think, oh, it's nothing to worry about. Oh, they recognize I'm not hearing so well, but they're so hesitant to take any steps towards it. And that is like the worst thing that they can do. And I think the data is around, and correct me if I'm wrong, but you know, the link between untreated hearing loss and early onset dementia is about a span of 8 years, yet people tend to wait about 10 years before they do anything about it. And so that's one of the things that we definitely want to just continue to raise awareness and make people aware of is do not wait. And like you said, it's no longer like, you know, you're completely stone profoundly deaf before a cochlear implant could help you more than hearing aids or other things. So that's really good.
Right. When I see the patients are on the trajectory of eventually getting an implant, one of the things that I do is I get them into an implant evaluation before they're an actual candidate. So you kind of like get them to thinking about it. So when the time comes, you have the relationship with them and they trust you, that they will more hopefully go through with it.
Awesome. That's fantastic. So if you're, for those watching us, so we haven't revealed this really cool thing yet, but so obviously, Chad is not only a bilateral cochlear implant recipient, but he's also a surgeon who does cochlear implant surgeries, which is such an incredibly unique perspective. So, I mean, you're the only one, right? Like in the whole, not only in the US or?
No, there are a few other surgeons who have cochlear implants and they also do the surgery. I can think of one in Germany, one in Israel, and one in Arkansas. And then there's me, and then there is one other person, but I think he retired, so 5 total. I'm probably the first one that is, I'm the first one that was born deaf and went all the way through college, medical school, residency training with severe hearing loss. And I think that it's very different for you to relate to patients if you are born versus acquired hearing loss. Because think of it this way, if you are a person later in life who has lost your hearing, it's very, very difficult. I'm actually thinking about surgeons because the surgeons who lose their hearing later in life, they already have their hospital system set up around them. They are a source of revenue for the hospital, and so the hospital doesn't want to disturb that relationship. Whereas if you are a medical student coming in with hearing loss, there's an incredible amount of discrimination and stigma that people have to overcome, and it's entirely different set of problems for sure.
Well, I have no doubt. And so that's still a super, super exclusive club that you belong to. But and speaking of about like coming up through medical school and going through residency and all on your surgical training. So you were you were the first to successfully do that, right?
With cochlear implants, there was a surgeon a gynecologist who came before me, and she actually communicated in American Sign Language. So I'm the first person probably to do it with cochlear implants.
Wow. Wow. That's so awesome. Congratulations. So
Thank you.
clearly that had to be extremely difficult. So tell us a little bit about that and how you persevered through that process.
Um, that was very difficult. So I think that people have perceptions of what deaf people can and cannot do. And, I had people tell me, well, you can't take care of an airway patient, like someone with a blocked airway, and coordinate their care, a coding patient in the middle of the night by yourself. Or you won't be able to hear certain things during surgery that are really important cues. And actually, none of that has ever really been an issue. Communicating with the team, I do that fine. There are ways to work around hearing loss. I have participated in emergency situations and complex airway cases many times. But what I did find was what I mentioned at the beginning of the interview, which was my problem with getting in was learning to advocate for myself, understanding how to communicate. And at the professional level is really, really different. And I think one way to think of it is one issue is like cognitive load, like how hard you're working to hear. Like a lot of people with hearing loss, like they hear a joke and they spent so much time hearing this joke that they're exhausted and can't think of anything witty to say, during at the end of the joke. Whereas my problem during interview and trying to convince people that I could indeed do this job was that I would spend so much time hearing, so much effort hearing that and people, they kind of tamp their body language down during an interview, and I couldn't read what they were saying because with an implant, you don't really hear emotions all that well in the voice, the tone of voice. And so being able to take in what they were saying and how they were saying it, and be able to think a couple of steps ahead and like guide the conversation is like really, really difficult. So one of the things that I tell all of my mentees now is to rehearse the conversation, plan for the branch points in the conversation, like how are you going to address X, Y, and Z, and be able to do it by being witty, being charming. And you do this because you've rehearsed it in advance, and you do it so well that the person doesn't know that they're being handled, And my mentees will come back and say, I don't feel comfortable doing that. It should be spontaneous and stuff. I'm like, our best politicians do this. Like Lyndon Johnson in the back of his limousine when he was chauffeured around, his driver told his biographer, Lyndon Johnson rehearsed entire conversations and he did it so well that the people he was talking to, the senators, congressmen, leaders, had no idea that they were being handled. So that's one way to get around it. So I know that's kind of like probably a little bit off of what you're talking about, but really learning how to communicate when you are not hearing everything is what is really crucial for hearing loss patients. And most people think that hearing everything is getting the words in the sentences. It's not just the words, it's how they're being said, like the emotion, the tone, and combining that with like nonverbal cues. That is the biggest challenge. And there are very few people who do that well. Michael Noble is one of them, actually.
I agree with you on that. He does everything well. It is interesting that you say that. So I was born with normal hearing, and like I said, I started to lose it at the age of 7, and then just had to learn to lip read and watch and be aware and just pay such close attention. And so it's so interesting because like all my girlfriends would come to me to tell me their problems, like in high school and stuff, because I would listen because I had to. And it serves very well as a life and confidence coach. But also, so when I moved to France, gosh, oh my God, I can't believe it's almost 12 years ago. That served very, very well, not being fluent in French, but to, just like what you're saying, anticipate, look at the nonverbal cues, look at like what's going on around you. That served me so well living in a foreign country where English is not the first language. So